In this video, I will be discussing cardiomyopathy. Cardiomyopathy is a disease of the heart muscle that makes it harder for the heart to pump blood to the rest of the body. It is basically the heart muscle disease from the word cardiomyopathy. There are 5 categories under cardiomyopathy: dilated cardiomyopathy, hypertrophic cardiomyopathy, restricted cardiomyopathy, arithmogenic right ventricular dysplasia, and transthyretin amyloid cardiomyopathy. These utilize diagnostic procedures such as blood tests, electrocardiogram, echocardiogram, stress test, Holter and event monitor, cardiac MRI, genetic testing, cardiac catheterization with coronary angiography, and heart biopsy. So what is dilated cardiomyopathy? Dilated cardiomyopathy is a decreased ability of the heart to pump blood because of the increased ventricular size and overstretched muscle. It is evident here, the dilated left ventricle and the thin myocardium, resulting to the reduced squeeze ability, the less blood supply to the body, and the buildup of fluid in the lung. So the risk factors of DCM are race, because it is more common in African Americans, sex, more prevalent in men, family history of cardiomyopathy, heart failure or sudden cardiac arrest, coronary heart disease and heart attack, diabetes and other metabolic diseases or severe obesity, disease that can damage the heart such as hemochromatosis, sarcoidosis, or amyloidosis, long-term alcoholism, and long-term high blood pressure. The pathophysiology of DCM starts with systolic dysfunction of the left or both ventricles, reduced sarcomere contractility that increases ventricular volume, producing the thin wall dilated left ventricle appearance that is observed in overt DCM. The signs and symptoms are the following: fatigue and weakness, heart failure, dysrhythmias or heart plaque, systemic or pulmonary emboli, S3 and S4 gallops, and moderate to severe cardiomegaly. DCM treatment are when symptomatic treatment of heart failure, vasodilators, control of dysrhythmias, surgery, heart transplant, and the pharmacologic good angiotensin converting enzyme inhibitor. This widen and dilate the blood vessels that reduces blood pressure, increase the workload of the heart, and increase the blood flow. Next is hypertrophic cardiomyopathy. It is a condition which the heart muscle is abnormally thick that results to difficulty in pumping blood. So it is, see here, the thick ventricular septum and the small left ventricle. The risk factors: it is most often inherited, happen at any age, but most receive a diagnosis in middle age. Pathophysiology: there is asymmetric ventricular hypertrophy in this area of the myocardial fibers, resulting to left ventricular hypertrophy that leads to a stiff left ventricle, resulting to diastolic filling abnormalities and obstruction in the left ventricular outflow tract. So the signs and symptoms are chest pain, shortness of breath, fatigue, arrhythmias, dizziness, lightheadedness, fainting, swelling in the ankles, feet, legs, abdomen, and veins in the neck. Treatments for asymptomatic patients: lifestyle changes and medication may contribute. The medications are beta blockers, calcium channel blockers, and diuretics. Procedures: septal myectomy. This is the removal of a portion in the septum that block the flow of the blood, and also alcohol septal ablation. This injection of alcohol in the uh, blockage, and heart transplant. Surgical implanted devices: implantable cardioverter defibrillator, pacemaker, cardiac resynchronization therapy device. Next is the restrictive cardiomyopathy. Restrictive cardiomyopathy is a form of cardiomyopathy in which the wall of the heart are rigid but not thickened. Thus, the heart is restricted from stretching and filling with blood properly. Here, there is a very stiff muscle, and since there is a high pressure in ventricle and high pressure in atrium, and the muscle cannot manage to pump blood effectively because it's stiff, so it results to less blood supply to the body and buildup of fluid in the lungs. The risk factors of restrictive cardiomyopathy are hemochromatosis, sarcoidosis, amyloidosis, connective tissue disorders, some cancer treatments such as radiation and chemotherapy. The pathology is the rigid myocardium increases diastolic ventricular pressure and ventricular filling, leading to venous congestion, and decreases carbon dioxide, resulting to jugular venous distension, hematomegaly, ascites, weakness, and fatigue. The signs and symptoms of restrictive cardiomyopathy are shortness of breath, fatigue, fainting, weakness or lightheadedness, cough, swelling in the leg and other areas, and abnormal heart rhythm. Treatments are lifestyle changes and heart transplant. Pharmacologic include diuretics, ACE inhibitors, anticoagulants, and antiarrhythmics. So next is arithmogenic right ventricular dysplasia. It is a rare type of cardiomyopathy that occurs if right ventricle muscles dies and replaced with scar tissue. So here it is evident that there is a body replacement of the heart muscle. The risk factors of ARVD are electrical instability, frequency of PVCs and sustained PA, pro-band status, extent structural disease, cardiac syncope, male gender, presence of muscle mutations or mutations in transmembrane 43, and lifestyle devoid of physical activity. ARVD pathophysiology is when there is loss of myocyte, it is replaced with fibrofatty tissue. And most common location for this tissue transformation is between the anterior infundibulum, right ventricle apex, and interior or diaphragmatic aspect of the right ventricle. Dysplasia leads to dilatations or aneurysm, expansion with systole instead of contraction. So now let's go on with the signs and symptoms of ARVD. The signs and symptoms are fainting, heart palpitations, dizziness, shortness of breath, chest pain, fatigue, swelling in the legs and other areas, persistent cough, and sudden death due to the abnormal heart rhythm. ARVD treatment are catheter ablation and improvement of diet or restricting salt in diet. Pharmacologic include beta blockers, antiarrhythmics, diuretics, ACE inhibitors, and coagulants. Next is the transthyretin amyloid cardiomyopathy. It is the deposition of transthyretin amyloid fibrils in the heart that is a life-threatening, progressive, and infiltrative disease. So here, there is a transformation, and it's deposited in here. So this is the heart of patients with transthyretin amyloid cardiomyopathy. The risk factors are family history of the condition, male gender, age of over 50, and African. The pathophysiology is there is abnormal assemble of transthyretin. And with this, it will clump, the protein will clump and shape into amyloid fibrils. The fibrils travel through the bloodstream and are deposited in many organs, including the heart. The accumulation weaken and stiffen the myocardium or the wall of the heart. So the signs and symptoms of ARVD are shortness of breath, fatigue, leg swelling and abnormal bloating, palpitation or abnormal heart rhythm, increased heart rate. Additional symptoms are numbness or tingling in the hands and feet, and carpal tunnel syndrome. Treatments include slowing and stopping the formation of depositing of fibrils, heart transplant, and liver transplant, since this is metabolized by the liver, the transthyretin. So the possible complications of cardiomyopathy are heart failure, stroke, heart rhythm disorders or arrhythmias, heart blockages, fluid buildup, heart valve infections, and sudden cardiac death. So nursing diagnosis is the decreased cardiac output related to left ventricular dysfunction and dysrhythmias. Outcome criteria include patient alert and oriented, skin warm and dry, pulses strong and equal bilaterally, capillary refill less than 3 seconds, BP 90 to 120 millimercury, pulse pressure 30 to 40 millimercury, heart rate 60 to 100 beats per minute, absence of life-threatening dysrhythmias, urine output 30 ml per hour, CVP or the central venous pressure 2 to 6 millimercury. The patient assessment, obtain vital signs every 15 minutes during acute phase, assess the patient for changes in neurological function hourly as clinically indicated, assess for skin warmth, color and capillary refill time, assess for chest discomfort because myocardial ischemia may result from poor perfusion, assess heart and lung sounds to evaluate the degree in heart failure. Nursing interventions are obtain BP hourly or more frequently if the patient's condition is unstable. Monitor hourly urine output to evaluate the effect of decreased cardiac output or pharmacologic intervention. Continuously monitor oxygen status with pulse oximetry. Provide oxygen at 2 to 4 liters per minute to maintain or improve oxygenation as ordered. Minimize oxygen demand by maintaining the patient at bed rest. Administer diuretic as prescribed to reduce preload and afterload. Monitor serum potassium before and after administration of loop diuretics. And prophylactic heparin may be ordered. Administer as indicated to prevent thromboembolism secondary to venous poisoning. So, thank you. That's all.